Thanks for joining us again at the Canadian Breakpoint, a Canadian infectious diseases podcast by Canadian infectious diseases physicians. I'm Summer Stewart, here with Dr. Rupeena Purewal, pediatric infectious diseases specialist from Saskatchewan. In this episode, we welcome Dr. Mahli Brindamour, pediatrician with the Saskatchewan TB Prevention and Control Program, to review complicated TB cases. Dr. Purewal.
All right, welcome to another episode of our podcast at the Canadian Breakpoint. Today we have a very special guest and actually a close friend of mine, Dr. Brindamour, who will be talking about complicated tuberculosis cases. So just an introduction, Dr. Mahli Brindamour is a general pediatrician with a special interest in global health. She works as a tuberculosis consultant with the Saskatchewan Tuberculosis Prevention and Control Program, where she supports TB care for children and adults in several areas of the province. She co-founded Saskatchewan's Refugee Engagement and Community Health, which is known as REACH Clinic, where she cares for refugee children with complex needs. She also provides outreach pediatric clinic care to the northern Saskatchewan communities of Isle La Crosse, La Loche, and Stony Rapids. So welcome, Dr. Brindamour.
Hello, thank you so much for inviting me. Such an honor to be here.
No, it's an honor for us because we have somebody who's an expert in TB, and a lot of provinces are seeing complicated cases. And so we've had a lot of requests to kind of talk about management. How do we manage these patients? And hearing it from an expert is a pleasure for us. And actually, it's a great follow-up episode because we just had Dr. Duillo on, who actually helped edit some of the Canadian TB guidelines that were updated in March 2022. So a lot of our listeners had a chance to review these updates. And so this is a great follow-up episode. So we're super excited to have you on board.
Oh, thank you. And that was a great episode. I listened to it, and it's a hard act to follow.
All right. So I think in terms of compared to our podcast episodes previously, this will be a bit of a different approach. So we'll be talking about a few cases, complicated cases, where we'll walk through the overview and the details of the case, approach to managing, how did the patient overall do, and really for us clinicians and other healthcare providers, how would we have managed this differently, and what resources do we have? And keeping in mind that the cases that you're seeing are in Saskatchewan, but definitely applicable to the rest of Canada and pretty much North America. So we have listeners from across the globe. And so we're kind of excited to hear some of these cases. And I would like to give a disclaimer that this podcast is for informational purposes only, and it does not replace an infectious disease or TB expert consult. All right, so with further ado, why don't we start, and I'll hand over the microphone to you, Dr. Brindamour.
Thank you so much. So I have three cases to talk about, and the way I chose them is I chose cases that were either complex in terms of management or complex in terms of challenging or challenges in accessing care or atypical presentations. And then we can unpack them and go through them. Perfect. And I also wanted to illustrate what kind of outcome we're trying to prevent when we care for these kids, and why tuberculosis in kids is such urgent to look after, important to think about, and be really persistent in finding the cases and following up. So the first case is really a tragic story. But what I wanted to outline was, again, what we were trying to prevent when we deal with pediatric TB. And so that's why I chose to talk about this case first, to illustrate how severe and horrible these cases can be, and almost 100% of the time preventable. Right. So the details have been changed. I changed the name of the communities and the name of the patients, etc. Changed a few details of their history so that they're not recognizable. But this case is about 4-month-old Victor and his sister Carla. And Victor presented to a peripheral emergency department, so not in a big city, but not in a small town either, with a 2-week history of cough, wheeze, and intermittent subjective fevers, as we say in PEDS, so tactile fevers. He was seen by the emerge doc, who did a chest x-ray because he thought, this is a little bit prolonged and odd, and he's little. And so that chest x-ray shows diffuse patchy consolidation, worse than a right upper lobe, and then this huge lesion that's described as a mass-like lesion needing follow-up, most likely due to infection, suggesting repeated chest x-ray in a few weeks, or CT, etc. So they consult PEDS. He's admitted on the ward, in the general pediatric ward for pneumonia. He started on IV antibiotics. And truthfully, this baby was on room air. He was systemically super well. He didn't really have any work of breathing. He didn't really have any findings on physical exam other than minimal intermittent wheeze. And so there was no rush or any acuity to that. And so they do a CT scan the next day. And that CT shows large necrotic paratracheal, mediastinal, and right hilar adenopathies that are obstructing the right mainstem bronchus. And he has extensive consolidation in the right upper and right middle lobes. And the report says, most likely malignancy, query TB. And so after that CT result, which is often what we see in cases of TB, is like, well, I can't rule out infection, but truthfully, most likely a malignancy. But a pediatrician looks at that, goes back to the family, and asks a few more questions. And what they find out is that the parents are asking, do you think this could be due to the illness that his older sister had? And the older sister died 2 weeks ago from an unknown cause. She just was found unresponsive at home and brought to the hospital, where she died in the hospital before kind of anything was done, other than a chest x-ray and a CT. And that chest x-ray and that CT showed extensive cavitations and tree and bud opacities. And there were some thoughts that perhaps her pulmonary artery was eroded, and that led to a subsequent hemorrhage, and that's how she died. There was no samples that were taken, and the family wasn't really kind of provided any explanation. And so finding this out, the pediatrician in the periphery is very worried, calls the TB program in Saskatchewan and say, have you heard about this baby? Like, is he on your radar? Have you treated this family or this sister before? And then, of course, we've never heard about them. We've never heard about the sister. We've never heard about the baby.
Okay.
But that story was so concerning that further investigations on Victor were done. And so, of course, this is actually atypical, but we found bacteriological confirmation for Victor. So they did gastric washings, and the gene expert for TB was positive, and the culture was positive subsequently. He also had an agra that was positive and a mantu that was positive. And it's rare that we get all of that. It's rare that we get bacteriological confirmation. Even the agra and the mantu often are negative. And so if we don't have the epi link, it's often very difficult to make the diagnosis.
Of course. So
we were lucky on that case. So he was started on regular pulmonary TB treatment with the RIPE regimen. And then he did quite well. He was followed by the TB program, had full recovery, and his chest x-ray post-treatment looked completely normal. And he's been done his treatment for a few months, and he's done really well. But then the question is, where did he catch this? Where is this TB coming from? So of course, the sister's case was suspicious, but we were never able to obtain samples. We tried to do postmortem, but that wasn't successful.
Okay.
So the TB nurses initiated a source trace investigation for the baby, and they also did at the same time contact tracing investigation for his sister that they considered as a infectious active, but that wasn't completely confirmed. And so through these investigations, they found a link to the kid's grandma that they were visiting often. And this grandma had family ties with several communities up north. And what she was doing is that she was supporting several people who had challenges with housing in her community, including one specific person who appeared to have been coughing for a very long time that she identified as part of the contact tracing. Okay. And this individual had no phone, no address, was very hard to find. And the TB nurses really persisted for several weeks. They sent letters to several family members in different communities, to his uncle, his grandma, his siblings. They phoned everybody who had a phone, and were really persistent, but they were never able to find him.
Right.
But eventually, some weeks pass, and then this person shows up at the TB program office because he got all of the letters, kept them.
Wow.
And then when he started coughing up blood, he said, maybe I have TB. I'm going to go to the address that's on those letters, and showed up. And through him, who of course he had TB, they were able to do the complete genogram that linked this person and these two kids to an area of the province where an outbreak was eventually called a few weeks after. And so everything kind of fell together and made sense, but it took several weeks of detective work for the TB nurses to find that. And in the end, so this guy is also on treatment, doing well, and recovered.
Right. Yeah. So quite challenging in terms of I think one of the challenges that I would face in that case is can never difficulty identifying the index case, right?
Exactly.
And contact tracing, especially when, you don't, especially in a province like Saskatchewan, where sometimes the address that we have provided for some of the patients isn't, their permanent address. And so there's a lot of moving around. And I'm sure similar in Manitoba, they must be experiencing that as well. So that is quite challenging for sure. And so
really, tedious detective work.
Yeah, definitely.
But it's really the contact tracing and the source investigations that will make everything make sense. Right. So I often look at these mapping and the genograms and the family trees, and it comforts us in our diagnoses, especially in pediatrics where it's so rare to get good bacteriological confirmation. When the links and the epilinks make sense, it makes me feel better about not treating them for nothing or over treating people when really the link is there. But sometimes it takes a long time to find it.
Yeah, no, that's fair. Yeah. So how would is there I guess locally in Saskatchewan, public health would be able to kind of help clinicians if they were in a situation like that where they need to get some help with contact tracing, or is it mainly TB control?
It depends. It varies province by province. I know that in some provinces it's public health that does that. In Saskatchewan, it's the TB program specifically that has TB nurse clinicians that are looking after this contact tracing. But there's lots of partnership going on, right? We do talk to public health, we talk to community health nurses in different communities, and it takes a lot of discussion with lots of people to help with that. But that would be in Saskatchewan, particularly the TB program that would be responsible for that.
Okay. All right. Yeah.
And then another thing to add about this, the importance of the genogram and the importance of the contact tracing is that through that, it's obvious to say for people doing this work every day, but that's how you identify high-risk contacts and prevent these bad outcomes from occurring in more babies. And so, for example, through this contact trace investigations, we were able to identify several active adults who were in contact with several other kids, and dozens of kids needed to be probed as a result. And we had at least 5 or 6 that I can think of active cases that were unearthed as a follow-up with contact tracing.
Wow. Yeah. So I guess again, like you said, the importance of going back and finding the index patients, contact tracing, and then really preventing such severe disease. That is the presentation. It's already very tragic to know that a child lost their life, most likely due to that. And then in kind of looking at even Victor's case here, that is a very severe presentation. where they're presenting with such significant CT findings. And we, that's actually disheartening to know that all of that could have been prevented.
Absolutely. Yes.
Yeah.
And Victor did really have the classic presentation of the adenopathies causing tracheal compression and a fairly rapid progression, right? He was only 4 months and had symptoms for only a couple weeks. And that's a classic presentation of a less than 1-year-old child who really with TB doesn't have the classic symptoms, might show up like a viral infection that doesn't go away, and doesn't have a lot of findings on physical exam despite potentially very severe disease.
Okay.
And same thing for his sister, where, she had a little cough for 2 years and she didn't see scare, so she wasn't identified early enough. There was this history where maybe she went to a walking clinic a week prior to the events, treated like asthma. There was no imaging that was done, but that's not necessarily atypical for how we would manage other children. So we really have to have TB, at the top of our mind all the time to find these cases.
Yeah. And I think so kind of like a couple of key points that I would take away from this case would be how important it is to contact trace, inform others if you're seeing any child that might have symptoms that are consistent with that. And then having that high suspicion of TB in the back, especially if you have TB in your communities and it's endemic in certain communities, and really thinking a chronic cough in a child that's not improving should probably warrant us to think about tuberculosis. So I think for some of our first line defense physicians out there who sometimes don't know anything about these patients, right? It's very difficult for them because, for instance, walk-in clinic physicians, right? They don't have a background history of these patients. They don't have their family history. And so, managing patients, but just keeping that on high alert, especially in a province like in Saskatchewan, where we do see a lot of endemic TB. So those are some of the things that I would take back and bring into my practice for sure. Is there any other key points that you think we should address, maybe for some of our listeners for this case?
Not for this case, and I think we can go to other key points a little bit later.
Perfect.
I almost feel like these key points for TB are so cliche, right?
I know
TB, it could always be TB, but really that's what it is.
Yeah, I know. And to be honest, I think it's knowing what's common in your, areas of practice, I think is really important. And it's always the same, if it looks like it probably is TB. And so we should always keep that on our differentials. So I think sometimes it's just good to familiarize ourselves and remind ourselves that it's still on the differential. Yeah.
Absolutely. Yeah.
All right. Do you want to walk us through the second case then?
Yes. So this second case is not necessarily a complex case because of her presentation, but it was really the treatment that was challenging for her and for everyone around her. So this is 4-year-old Claire. And her case not only talks about barriers to accessing care, but also the stigma surrounding TB that is very, very strong everywhere in the province. So anyways, Claire is 4, and she was identified through contact tracing, again, of a smear positive pulmonary TB case. So she was a high-risk household contact. And because she's less than 5 years, it's urgent. So we tend to see these kids, or we want to see these kids quicker, and we do more investigations and have a lower threshold to see them faster than others. So as per the guidelines, we needed a skin test right away as soon as she's identified with a MEN2, and then a repeated MEN2 if that one is negative at 8 weeks post-exposure. And then all kids less than 5, we do a chest x-ray, in addition to symptom inquiry and a physical exam, etc. But just that was very complicated because the family struggled with unstable housing. They didn't have a phone. And so they were very difficult to find. We, again, called everybody we could, sent letters to the clinic in the community where they lived. We contacted family members. And on top of all of that, it was in the middle of COVID. So that was the first year of COVID. So all of our clinics were canceled, and we were only doing telehealth clinics, which really isn't ideal to go look for people in their community.
Right.
And the TB workers, who are really miracle workers in the community where she lives, tried to go to their house multiple times, but people would not answer the door, would not want to talk to them, or everyone was sleeping. Anyways, it was a hard time, and it took many weeks before we could talk to them. Then the next barrier was, how do you do a chest x-ray? You don't have a chest x-ray machine in that community, and they need to drive or find some transport to go in another community an hour and a half away to go do a chest x-ray. This family has several children, they work. It's very complicated to do that. So booked her 6 times for a chest x-ray, and she never went to do the chest x-ray. She did have a skin test, but she never came back to have it read. So, we can't piece out our information that we need. So eventually we succeed in talking to them. And in talking to the family, we decided, would it be easier if we brought you to the big city to see us, and we could, do everything at the same time, examine you. We would see all the family members at the same time.
Yeah, that's right.
And to me, that sounded very overwhelming, and I didn't think they would do that. But somehow that was their preferred way of doing things.
Okay.
They organized for them to come, and they come. And so we're able to do the chest x-ray. We do an IGRA. We examine the child and the sister, who was also was 6 at that time and was also a contact. And so we see them in our little TB room in the hospital, like in the old part of the hospital where there's no window and there's not really an examination bed. And so Claire she's busy, she's climbing on the wall, she's playful, she's curious, she's very, very chatty.
Yeah.
And her symptoms, like, she doesn't have any symptoms. No cough, no fever, no fatigue, no decreased appetite, nothing. She's running around, happy, nothing. Her exam is totally normal. Her sister's coughing a little bit, but that's it. And then the chest x-ray comes back, and it looks maybe a little bit viral. We've all seen these chest x-ray with a bit of patchy perihilar thickening, not super worrisome. In any other child, we would be like, it's fine.
Right.
She gets an IGRA. We get the result of the IGRA a few days later, but it's positive. And then, because she's been so hard to find her, the chest x-ray is not quite normal, we decided to admit her for gastric washings on that day. Met her and then do gastric washings, and the parents are a little bit overwhelmed. Like, that's not what they were expecting, and that's a lot more investigations than what they thought. But the TB nurse who saw them was like, I'm not sure about them. We better investigate them more. We might not catch them again. So anyway, gastric washings, and the PCR on the gastric washing comes back positive. And the resistance pattern comes back indeterminate for resistance. Further down the line, we found out that the culture was negative, and that was the only kind of clue that we had to diagnosis. And we also did a chest x-ray in the sister, and her sister had a completely normal exam, but she had a left lower lobe consolidation and air bronchogram on her x-ray, and a hilar adenopathy. But she had a negative IGRA, and her gastric washings were negative. So you can see how the clues to diagnosis are quite challenging. Anyways, so we decide that we're going to treat them both as active because we know that they had a really high risk contact. We have a positive IGRA, we have a positive PCR in one kid, and abnormal chest x-ray in the other kid. So we decide to treat them. Okay, we give them their first dose in hospital. It goes well. They go back home. And then a couple weeks pass. And then we start getting calls every day by the TB workers in the community who are giving them their directly observed therapy in the community because they're struggling with Claire. So they go to the house every day, and then no one opens the door. Everyone is sleeping. The kids have a reversed sleep cycle. So they sleep all day. Even when they get into the house, it's impossible to wake up. they spend 2 hours at her house every day. And when she does wake up, she bites the TB workers, she spits on them, she swears at them, and the TB workers are actually becoming afraid of her when she's 4.
Yeah.
And so when that occurs, we try to mix the TB meds and all sorts of, nice tasting things. We try Nutella sandwiches, we try slushies, we try on a day where people were particularly desperate, we tried Red Bull. But that didn't work. She kept on spitting and biting, and everybody was getting worked up and traumatized, right, through all of this.
Yeah, for sure.
Parents and the TB workers, it was just awful.
Yeah.
Then we tried to bring her to the TB to the clinic to give her the medicine there. Tried to hold her down. We tried to put NG tubes. That wasn't working out. And we tried incentives for her family, incentives for her, like age-appropriate toys, sticker charts. We tried to give her candy. We tried to talk to the family to say, like, how do you have anything that you need in your house that we could help with? The TB workers were bringing groceries every day to help with food insecurity. We wrote letters for housing. And then eventually we had meetings with several community members, meetings with elders, with the holistic program in the community where they live. Try to kind of have everyone on board to make this child take her treatment. And everybody was very much on board, but the child would just not take her treatment. And we worked at that for quite a few weeks.
Yeah.
Meanwhile, she remained well. She was clinically fine. But people in her community and her parents and the TB workers were getting pretty worked up because there were several bad outcomes at the same time from tuberculosis in that same community. So people were in the ICU. There was a death in a young person, not a child, but people were quite afraid for her.
Yeah.
So we needed to do something.
Right.
So in the end, we held another meeting with the family and elders in the community, and we decided to bring the child to Saskatchewan and work with the Child Life program to work on medical play and trauma associated to healthcare, so that we could eventually give her treatment. And so she worked with them every day for several weeks. And after 2 weeks, she was able to take her medicine after a few hours. And eventually after a month, she was taking the medicine on her own. So it took a very long time, but then she went back to her community and finished her treatment. We had to restart her treatment entirely because
you lost so much time.
We lost so much time, and we restarted, and then we couldn't trust that she had the right number of doses anyways. But through that and the excellent work that Child Life and her parents and all the efforts that were done, we were able to finally complete her treatment. And so was her sister. So her sister struggled less, but she was seeing this, and it was also difficult for her anyways. And so when they both finished their treatment, we had a little celebration with cake, and we had identified like something that they wanted for the end of their treatment. So they both got an iPad, and it was very lovely, and everybody was so proud of what we accomplished, and the good work that everybody had done through that. But it was very difficult, and it even raised some concerns for the TB program about trust building in the community, right? So we knew that there had been some bad outcome, and there was potential danger in losing the family and the community's trust, and we had to navigate that very carefully, and also not too forcefully, right? Because the tuberculosis in Canada is so linked to colonialism and racism and medical trauma, etc. So these are very sensitive areas to navigate.
Wow, that is very challenging, but I mean, definitely rewarding. So like, definitely pat on your guys' back, because that is impressive to go through all of those challenges. I mean, there was so many challenges with like diagnosing in this case, access to care, just transportation in general, actually basic health needs that weren't being met, that was probably also creating a huge challenge in this case. And this is not uncommon for a lot of, provinces or centers that are experiencing TB outbreaks as well. And so I think a lot of our listeners probably relate to that. So in terms of, one thing I took from this was that you need to have a multidisciplinary team. That is huge.
Yes, it is huge. Yes. We
Right?
don't have a social worker in our program.
Yeah. So that's what I mean, right? It's like, if you need a program to be running this efficiently, like this to me, obviously I'm looking at it from an outsider viewpoint. I know the end outcome. I'm sure it was like, there's many more hurdles in between that we didn't even speak about during the case. But in general, just looking at, without having multiple people involved in this case, there would be a limited chance to run a program so efficiently. You need to have, just the morale too, first of all, because it's almost like difficult to continue pushing yourself to try to advocate that we need treatment, and we all talk about, how the diagnosis is difficult, and, all of us kind of hone in on that it's very difficult to diagnose. But treatment, I personally, if I had to take a medication for 6 months or longer, I think it's challenging. And now we're asking children, to do this for a long period of time. So I think, a couple of things that maybe our programs need to also look into is that as TB increases and pediatric TB is increasing, maybe we need to kind of increase our resources to make it more child friendly too, right? So I think you mentioned some good ways of, hiding the medication into different tasteful foods. That's an approach that I think all pediatricians are used to doing, especially in our infectious disease world, because antibiotics also don't taste great, a lot of them. So yeah. And so, but definitely I think coming up with having child life support, right? So not every center would have that ability, right? And so I think a lot of programs should likely reassess, and have to reassess what resources they have and what resources they may need if we continue to see, obviously, this much pediatric TB and complicated pediatric TB, where, it's not just the complications around the actual diagnosis and using medication that's resistant. Because I know in adult TB, a lot of times we'll face a lot of resistance, or even foreign-born children that are coming into Canada and they have tuberculosis. We see a lot of the resistance as a complication. But in this case, it was already complicated enough to know that the sister didn't even have some of the, clinical findings, whether she's living in the house and she has the symptoms, and then she has these diagnostic tests that are not indicative of TB, right? So, wow, that's challenging. So I guess one question I want to pose, and it is about the diagnosis, because I get asked this question multiple times a day. And so I think it's nice to address is the difference between, so when do we know TST versus IGRA, and what is our reliability? And if somebody is a contact, like how the sister was in this case, but her IGRA was negative, but she's a contact. In this case, you guys started her on treatment and you prevented any long, term complications in her. Is that the approach that you would use in most children then?
Yes. The answer to this is complicated. And I think as the more I progress with learning about TB and doing TB work is one needs to be comfortable navigating the gray. Yeah. There's no black and white answer, especially in pediatric TB. So the official answer is for IGRAs and skin tests. So skin test meant to TST is all equivalent, right? So we have good evidence to say that screening for kids older than 5 years old, IGRA is equivalent to TST. For kids who don't need serial testing, IGRA is appropriate. The problem with IGRA is that it's often not available in smaller communities, smaller centers. It's a very finicky lab to get. We often don't have access to that other than in hospitals. And then TST is always fine to do in everyone.
Mm-hmm.
From 2 to 5 years old, there's a little bit of a gray zone where we think that IGRA is probably fine, but we don't have the greatest evidence. And under 2, we also think it's probably working. We have a little bit of evidence. I think it is coming, but we don't have hard evidence to be able to say for sure use an IGRA instead of a TST.
Okay.
In the end, oftentimes in kids where you really want to make sure, sometimes you might do both, and that might be helpful. But the end of the story is an IGRA or a TST helps you identifying TB infection and not TB disease. And oftentimes, especially in kids, the smallest, the more often you will see this is that in active disease, they'll have anergy and their TST will be negative and their IGRA will be negative.
Right.
It is reported as being, 30 to 40% of cases of active TB, which is huge. And so a negative screening test doesn't rule out in any way TB infection or TB disease.
Right.
Now you have to work with your risk factors and exposure and epi data to see how much, or to decide how much importance you're going to put on a negative test.
Right.
And that's the gray zone when the application comes handy. So for them, these sisters, they had a clear epi link. They were exposed to a 4+ smear positive pulmonary case for extended periods of time. One of them had symptoms, and we did have bacteriological confirmation for one of them. So it all made sense despite the screening tests in the older girl.
Yeah.
But in someone who doesn't have contact, no risk factors, no symptoms, normal imaging, well, you might ask yourself, why did you do the screening test first? But a negative test doesn't might need more.
Right. Okay. No, that's fair. Yeah. And I think everybody who sees TB or manages TB or has, been around, like even our pharmacists who've been around anybody who's managing TB kind of knows that there's always this gray zone. And if the kind of the clinical picture is there, then it's probably more likely reliable in that case. Yeah. And then you have that contact, right? So
yeah, absolutely. And that might be me being careful. And I think everyone works differently depending on their experience and their comfort level. But especially if there's an epi link, I verge on treating other than and especially treating for latent when I'm not sure. And I either wait and observe if they're well, which we can totally do that, right? TB will eventually declare itself, or treat.
Yeah, that's fair. Okay. So before we move on to the third case, I want to just touch on, you mentioned the stigma around TB. So are there resources or, like as healthcare professionals, like for us, like we mentioned that we don't have a social worker on our team, but in general, like, are there some resources that we could help families with the stigma? And obviously, what's something that we can lessen the burden on them, because I know that could be very challenging, especially in some of these communities that you're going to and you're working in and have outbreaks. It's very difficult for people to not, find out or know what's going on, right? So is there any kind of guidance that you would give, since you've had some experience in some of these northern communities?
It's something that I find very difficult to navigate. And it often comes to relationship building and trust building, and forming relationship with the entire community, knowing the place that you work in, and knowing the TB workers and the elders, and finding out, if possible, what is it that people are worried about, goes a long way. And the consistency in the people working in those specific community can also be very helpful. But again, that's easier said than done. in the new Canadian TB guidelines that were just published in the spring, there is an entire chapter that's dedicated to kind of cross-cultural care and working in communities that have been traditionally stigmatized and marginalized, which is a really good resource for healthcare provider that I would encourage you to read.
Perfect.
But in terms of people living that life, there's lots of people who have memories of being in the sanatorium and being taken away from their family and coming after years, and all of that is very traumatizing and still very present in people's minds and lives. And so addressing this slowly and gently, I think is helpful, but also and again, I feel this is almost cliche to say, but again, addressing the reasons why people found themselves in that place, right? It's because of, societal mistreatment over generation, living in poverty, unstable housing that's not been updated, and food insecurity, and all of that weighs a lot more in people's minds, and it's so addressing that will also help with trust building, and it's so important to the work that we do. Like, we couldn't treat TB if we didn't have the resources to support that somewhat, even though whatever we're doing is insufficient.
No, that's a really good point. It's challenging. I mean, it's something that's going to take a lot more years probably, and a lot of support, and I think having the resources that we have now, I mean, I think we're already definitely better than we were a few years back, and I think everything is moving in the right direction. So
yeah, I agree. And I actually I work with this wonderful TB nurse that is a mentor to me, and she said, I think people in the communities where there are currently outbreaks and are potentially communities are isolated and traditionally stigmatized by the rest of society, people are doing a beautiful thing, seeking care and bringing their children to medical attention and accepting the screening, and participating in contact tracing. They're working for their community, and this is what is most helpful. And showing this and putting light on this, I think from my small, ignorant perspective, might help with decreasing the stigma, and putting power back into people.
Yeah, no, that's a fair point. And really like commending like those that do come forward for screening and saying, that there were a case or they have symptoms, that type of thing, despite the stigma. So I think that's actually a very good point you bring up.
And these good outcomes of success stories of patients who finish their treatment are helpful. We did notice even after that case that people would come to the clinic worried about TB, being like, my kids were in contact with X person and X person, should I be worried, and asking more about it. And this is what we're hoping for, and that's also I think such an extraordinary
and I love the idea of like celebrating at the end. That was great.
Oh yeah, I love the parties.
That's awesome. That's great. All right, so why don't we move on to the third and the final case for today? And this has just been like, already it's like so informational, so I can't even thank you more, like, enough for being on the podcast today. It's great.
Oh, thank you so much. I mean, I could talk about this all night, but I don't think we have time. Okay, so let's do the third case, who is a 12-year-old girl who we will call Lindsay. And Lindsay presented to a walking clinic in the fall. And her presenting concern was that she had worsening back pain since the previous summer, but not much else in terms of other symptomatology. She didn't really have any red flags at that time. She didn't have any fever, weight loss, etc. The pain wasn't waking her up at night. And she came to this walking clinic in a medium-sized city where TB, I imagine, wasn't necessarily top of mind when she was seen. A teenager that comes with back pain, we see this every day, right? But in any case, there was a spine x-ray that was done at her first presentation. And then that showed, I wish I could show you the x-ray. So it showed a small lytic lesion at T8. And the report says MRI is recommended, follow-up recommended. And then there's a CT that's requested by the physician who saw her at the walk-in clinic, who's not like a clinic that knows her or will follow her up or anyways, but they requested that CT. And then not much happens for quite a few months. And eventually her parents are like, oh, right, like she still has back pain. There was supposed to be a CT. What's happening with that? They phoned the clinic and they discovered that the requisition was lost. That's 3 months post her initial presentation.
Oh, geez.
And of course, in the interim, her back pain has worsened. She's missed weeks of school. And then she developed progressive leg weakness. She's not able to get up on her own. She falls a lot. And then, quite worrisomely, over the last week, she noticed that she's been more constipated than usual, and she's been having difficulty passing her urine. Anyways, so there's an urgent CT that's organized for that same day. She also developed fevers, night sweats, and has lost 10 pounds since she was last.
There we go.
So there you go. And then the CT shows that lytic lesion at T8 that's grown is destructive. There's destruction of the vertebral bodies and posterior elements. And then the report says these findings are very concerning for Ewing sarcoma or lymphoma. Possibility of CRMO should be explored. Infection is less likely. And I think you were actually involved in this case. You probably remember.
Yes. Yeah.
So after that CT, that same day, she's sent from that mid-level city to a tertiary care center that same day, and she's admitted under ortho, and oncology is consulted. And she has a workup that's initiated for sarcoma with a full body PET CT and MRI of her spine. Both ortho and oncology's reports like very likely malignancy. The MRI report, the PET CT report also say that. And there's an OR that's booked the next day for decompression of her spine. And then on the PET CT, they're described that lytic lesion from the CT, but there's also another lesion at T5 that's suspicious for Mets. And she has a small pleural effusion with a small pleural nodule that they say is also suspicious for Mets. Her lung parenchyma is normal, and the rest of her PET CT is normal. And then they think about consulting Dr. Purewal for rule out infection before her OR. And Dr. Purewal, who's seen crazier things, says, make sure you send samples for TB in addition to all of these other things.
Yeah.
And in doing a very thorough history, like PedsID likes to do, I think you found out that she had ties to one of the communities where there was outbreak. She actually went back and forth from this community and spent a lot of time there even before her symptoms started.
Yes.
She even lived in that community for years before she went to high school. Anyways, that's in the background. While she's going to the OR, they decompress her spine. It's a very long surgery. There's 2 surgeons involved. It was very, very complex. But they resect the mass. And then they send the sample for PATH. And on the same day, we get a preliminary report, no malignant cells. But there's granulomatous inflammatory infiltrates and some necrosis in the sample, which is non-caseating, but nonetheless, some necrosis. And then we fast-tracked the TB PCR on that sample, which came back positive. And that's when the TB program got involved. And eventually, her IGRA came back positive. And the sample from her OR, the culture grew MTB, which was pan-sensitive. So she was treated like disseminated TB of the pleura and bone. Was put on 9 months of TB treatment with the traditional RIPE therapy. And she had an excellent outcome. If you look at her CT images post-treatment, it's fully resolved. There's no sequelae at all. But most importantly, she's walking. And she doesn't have any neurological sequelae from her bony osteomyelitis, tuberculosis. So again, I think the lessons from this case are almost cliche and so classic, which, in tuberculosis, in children, early identification is so important to avoid dramatic and horrible outcomes where she could have potentially been paralyzed, right?
Yeah, exactly.
Or have further dissemination. And, we want to avoid death and horrible disability in everyone, but particularly in children. But also, often when there is a mass in the picture, the malignancy will be top of mind, and people will not necessarily think about including TB in their differential unless there is clear causes, clear links to epi, epi. She did have, but they were a little bit difficult to find.
Yeah, no, for sure. And I do remember this case being challenging in the sense that, I mean, most of the time, and I always teach my learners this too, is that it's really, really, really difficult when you're called and somebody says, oh, this is a mass, because mass in everybody's mind, tunnel visions you to malignancy.
Especially when all of the reports and all of the subspecialists kind of grasp that and say, yes, it fits with the viewing coma, et cetera, et cetera.
Exactly. So I think like in this case, I mean, like any other case, I always tell learners is like, you have to step back and remember that you go in with a clean slate, take your history, find out information, and getting collateral information, especially in like teenager patients, I've noticed is like really important because sometimes they can't remember. I mean, life is changing, right? Like things are happening all the time. Everything's a blur. And so it's, I think, really important to be asking parents and, whoever else is in close contact with the family, that type of thing. So, and really not getting tunnel visioned. And it's so difficult though, because I mean, especially for consultants, because you're told, here's the clinical question. And can you help us? Like in ID, it's a little bit different because everybody always says, can you rule out infectious disease? I wish there was like a list of 10 diseases that I could rule out for everybody. But, but in the end of the day, it's our job, right? Like, just like how you're a detective in TB world, I'm like a detective in the infectious disease world, right? So like, I have to put the pieces together and always remembering that the story has to fit, right? And if there's something off about the story, like the age group or the presentation, then always reconsidering, like maybe this isn't the diagnosis and maybe I should think, maybe there's other things. And that's why we do all these tests, right? So that we can actually, I mean, most of the time it's to rule out certain diseases, and like some of the times they rule them in, which is great. And I mean, knowing that the utility of like, we're very lucky because we have a lab that can do, a PCR based test for us quite quickly on requests. Even I remember this case being on a weekend. So it was a Friday afternoon and like Saturday morning, we had the PCR result back, right? So I think like we're fortunate that we're in a center that we're able to do that. And some centers may not have the capacity to do that, but just remembering that if you have quicker diagnosis. And we knew that going into this, we're going to get a good tissue sample. So tissue is ideal, right, for sampling. So whenever in my world, if a tissue is positive for something, I mean, the yield is there, right? So if we can send it off and we always talk about in guidelines, like if it's fluid and or even sputum and there's less than a small amount, like less than a mil, we always make sure that culture is sent over PCR molecular based testing as per our guidelines, which is very accurate to do because we should be doing that so that we can actually definitively diagnose and then also follow the resistance patterns and sensitivities. But in cases where there's going to be an ample amount of tissue and you need a rapid or ample amount of specimen, you need a rapid diagnostic test to kind of help you rule in. I think PCR molecular based testing is definitely very helpful. So it was for this case, at least for me. So
absolutely, yes. And tissue in TB is always the best yield. All the other samples are, notably not very good, and so a negative sample doesn't necessarily mean anything, as you know, of course. And then for the PCR, what is interesting is that it's not validated for many types of samples, and so often. Again, if it's negative, one has to remember that it doesn't totally rule it out. But when it's positive, then that definitely will give you a lot of clues towards your diagnosis. And anywhere you can do a gene expert sample, you can use the same machine to do different samples. And so I know that some remote communities have gene experts for influenza, etc. And I believe you can still, and this is like, non-validated, but in a pinch, you could use this machine to test like a sputum sample or gastric washing sample for.
Right. Okay, that's good to know. I mean, especially like, in a situation where you don't have much for resources or you can't transfer the patient to a bigger center, right?
Yes.
So, yeah.
It's often big obstacles.
Yeah.
But then in terms of malignancies and TB, those are often, like you said, right, there is a mass, and so people look for that. You need to rule out malignancies, right? Because this is also what's going to kill people. And TB and malignancy go hand in hand, you talk about malignancies, TB is often in the differential and vice versa, but it can also happen together.
Right.
You have seen this, people with, classic presentation of TB adenitis, but then you do a biopsy and you do find out that they have a lymphoma. And so really being careful about not missing one when the other is present, but also making sure that people don't have both things.
Yeah, no, that's actually a really good point, right? And so a lot of these like diseases that are mimickers of one another, right? And we kind of classically always talk about this indolent presentation type of thing. So the workup has to be extensive, but keeping a broad differential, right? That's what we practice. So I think that's at the end of the day, always remembering that there could be multiple things going on. And I think if you come up with a broad differential to begin with, it's easier to manage these cases. Wow. So super interesting. So we went through kind of the social concerns with managing TB. We talked a lot about access to care and complicated cases in terms of, just clinical presentations and contact tracing. And then another case where, diagnosis sometimes is so difficult and it's missed at times. And really keeping that in mind that some presentations can mimic TB. And if it is endemic or if there is any suspicion, really getting a thorough history and really knowing, I think, which communities in your provinces have higher TB cases and, keeping in touch with public health. And I think for some physicians, it's a little bit easier. Like I work daily with public health, so they're always hearing from me. And so I think, and similar to like a TB program, you guys will be in close touch. So I think like encouraging other physicians, even if you're out in the community practicing somewhere, it's okay to call the medical officer of health or, reach out to your TB program and see if this is a community that maybe somebody's listed as a contact, because that might just guide you to the right direction and prevent any type of complication that we just talked about. So
absolutely. I was actually going to bring this up. So in Saskatchewan, I'm not sure how it works in other provinces, but I imagine it's similar. There's a TB physician on call 24/7. And as with any other consultants, it's totally okay to phone the TB physician with a question. Like you're not sure, did you think about TB in this specific case or not? And if so, what kind of investigation should you do? And that's why we're here, right? And we're able to see, is this person part of an ongoing contact trace? Or maybe they were under our radar, we're trying to reach them. And so it's useful for everyone, including the TB program, to receive these phone calls. And I would say with kids, if you're not sure, it's always urgent. If TB pops in the back of your subconscious, call the TB physician.
Yeah, that is great advice. Yes, because sometimes, especially with even pulmonary TB, sometimes it's difficult because a lot of these patients are on like weeks of antibiotics first, right? There's like this non-improving pneumonia, which then ends up sometimes being, because it doesn't really always have to present cavitary originally, right? And so I think it can be really, really challenging, but always keeping in the back of the mind, if there is any suspicion, it's better to just call and use your resources.
Absolutely. Yeah. Even if you don't have any confirmation of anything and it's just a question, it's always fine.
Yeah. Well, that's fantastic. Thank you so much, Dr. Brindamour. That was honestly, it's just so refreshing to go through some cases because all of us are always thinking about different diseases and different conditions, especially living in a province where it is endemic to have TB. A lot of our listeners, they've reached out and they want to talk about it. We know that there's TB outbreak areas here. And so we've gotten a lot of questions regarding it. And so I think this combined with the new guidelines is a really, really, really great resource. I think all learners, all physicians, especially within Canada where we are seeing an uptick in our cases, we should all be familiar with this. So I want to thank you for coming on the podcast, and it was a fantastic episode, and we look forward to having you back again for future cases.
Thank you so much for having me. I was so honored to be here. Thank you so much.
Thanks.
Thank you, Dr. Purewal, and thank you, Dr. Brindamour, for joining us. Have a topic suggestion? Email us at thecanadianbreakpoint@gmail.com, and be sure to follow us on Twitter at CA Breakpoint. See you again soon at the Canadian Breakpoint.